Good afternoon, everybody. My name, like you said, is Tommy Brown, and I'm from SAMC. So I have nothing personally to disclose other than the standard military disclaimer. So a little background. Stage 1 through 3 HER2 overexpressing HLA-A2 and A3 breast cancer patients are at a high rate of recurrence. Trastuzumab is a HER2 targeted monoclonal antibody and is the standard of care in HER2 overexpressing breast cancer and has been shown to decrease recurrence. The novel treatment, which is the focus of this trial really, is E75, which is a peptide vaccine that targets a specific epitope located on the HER2 molecule and has been previously shown to be safe and immunogenic. E39 is also thought to work synergistically in combination with trastuzumab. So this is a diagram of our group's HER2-targeted peptide vaccines. E75 specifically targets the extracellular domain of the HER2 molecule, interacting with MHC class I HLAs A2 and 3, leading to the stimulation of cytotoxic T lymphocytes. Given that trastuzumab has a known cardiac toxicity, which is thought to be related to its effects against HER2's cardioprotective role as a growth factor receptor, we must ensure that the addition of another treatment against HER2 will not worsen this complication. In this trial, we enrolled patients with HER2 overexpressing breast cancer that were at a high rate of recurrence after their initial standard of care treatment, usually consisting of surgery, neoadjuvant or adjuvant, trastuzumab-based chemotherapy, and radiation if it was indicated. Patients were randomized to receive either trastuzumab or trastuzumab plus E75. Cardiac ejection fractions were measured both at baseline and then serially throughout the trial. In addition, safety and demographic data were collected and analyzed once the 50th patient had been enrolled. The vaccine group intradermally received 1,000 micrograms of E75 plus GM-CSF, which is an immunomodulating stimulant given with intradermal vaccinations. These vaccines were given every 3 to 4 weeks after the patient received their third post-op dose of trastuzumab, while the control group in our trial received trastuzumab plus GM-CSF alone. The primary vaccination series consisted of 6 total inoculations with follow-up boosters given afterwards at 6-month intervals. Once the initial 50 patients were enrolled, the demographic and safety data were compiled. There were no statistically significant clinico-pathological differences found between the vaccine and control groups. There were no related grade 4 or 5 toxicities found, and no differences in related toxicities grade 1 through 3 in the vaccine or control groups either. And likewise, there was no statistically significant reduction in ejection fraction pre and post treatment with the combination therapy of trastuzumab and E75 versus the control group. So in conclusion, the combination of trastuzumab and E75 has been well tolerated, and the cardiac effects of trastuzumab have not been shown to worsen with the addition of E75. Our enrollment goal for this trial is 100 patients. In our primary analysis, once this is completed, to include immunologic and clinical outcomes will be released after 24 months of follow-up, which will be soon. So, any questions?
Thank you very much for your presentation.